That's fine.
I'm going to be speaking briefly about the threats of epidemics that we've had since Ebola ended. Two things I want to say. Infectious disease anywhere is infectious disease everywhere. And we have to be cognizant of the fact. Yellow fever in Angola spread to Europe. Less than a week ago, monkeypox from the UK, from Nigeria into the UK, and people got infected. We face this issue every day. Neglected spots of today are the hard spots of tomorrow. So I have this map that tends to show you the level of preparedness in the West African region towards epidemics preparedness. You see predominantly most of the countries in the West African region are in red. There's no level of preparedness. And if you establish with me the premise I have laid that infectious disease anywhere is everywhere, that the neglected spot of today are the hard spot of tomorrow, you can see, except that Liberia and other countries in yellow are making some progress due to the lesson learned from Ebola, and also want to recognize the World Bank effort on the REDISI grant that is trying to do regional surveillance. There is so much investment into regional surveillance. Treating the epidemiologists of tomorrow, building laboratory capacity is a very good step in the way forward, because if you understand infectious disease, like our monitor what's going on in the DRC, it worries me every day. I'm watching the trend, and I hate to say this, but I'm so convinced that there's a bigger threat that it could spill over in the other country for a potential situation, because we saw all the errors that happened in Liberia repeating themselves in the DRC. The resistance, the military, so there's a perfect sum there. So we want to acknowledge the investment, but this can tell you the situation in West Africa. I will now narrow down to Liberia. If you compare 2017 to 2018, you begin to see that there are increasing cases of outbreaks that includes Lassa, that as I speak to you this very moment, yellow fever has been diagnosed in the southeastern part of my country. Lassa, we have had consistent spread of measles in the country. We have had re-emerging of new diseases. Are we seeing the increase in outbreaks because of Ebola, and we have enhanced our surveillance capacity? Dr. Richard Cash used to say to us, when you look for it, you will find it. Are we finding it because we are looking for it? But it shows you that there are increasing outbreak in Liberia. I want you to watch carefully what's happening over 3 years period. We're seeing increasing cases of Lassa. In Liberia, we have, like Dr. Fashi said, Lassa was restricted to certain seasons of the year and certain area we call the Lassa belt. But for the last couple of years, there is breakage down from the Lassa belt to more counties. Not only that, but we are also beginning to see that it is lasting more longer, and because it is lasting longer, we're having more cases of Lassa. I shared this slide. If you look across 3 years, you watch the number of cases we've had, the number of confirmed cases, you will see that in 2018, the case fatality rate has increased as a function of the number of cases, the severity of the disease. And that continues to tell you that we're going to face greater threat every day. Not only are we seeing that the epidemiology and the biology of diseases that we knew are changing and posing more threats and killing more people, but we begin to see re-emergence of new disease. Yes, we begin to see, you see monkeypox. Since the 70s, monkeypox was essentially eliminated from Liberia and West Africa. Last year, we begin to see new cases of monkeypox across the country, spread across the country. Monkeypox is no more restricted to Liberia, but we see cases in Sierra Leone, we see cases in Liberia, Central African Republic, and as I said to you, Nigeria, where 2 cases got imported to the UK, and someone in the UK got infected. So the chances of, I always say to people, I can have breakfast here today, and I can have my dinner in Liberia with the global travel. I can be incubating a disease this very moment from the US, and I will be in Liberia and spread it. We saw that happening with Ebola. Okay, another case here. For a long time, we were blessed. Liberia was also of the meningitis belt. All of a sudden, we're in a conference in the US, the Minister of Health. We had a cluster of death. 8 persons died from symptom onset to severity to death 24 hours. We were very confused. All of a sudden, we thought it was Ebola. We went around through metagenomic sequencing at the CDC. We realized that it was septicemia meningitis serotype C. This was not expected in Liberia. Liberia was not in the epidemic belt, the meningitis belt. All of a sudden it went back, and the third and the most important one that is so critical from a global health perspective was the one in the northwest. This is the boundary between Liberia, Guinea, and Sierra Leone, the red circle, where Ebola started from. This is where we had a big outbreak. And to make it more interesting, the outbreak was ongoing during the inauguration of our new president, where international guests were flying in, the airplanes were coming into Liberia. We had to deal with the issue of information management, keeping the outbreak contained. We had to move in massively with ciprofloxacin, and were able to treat over 1,000 people to prevent a spillover into Sierra Leone and into Guinea, and to ensure that we kept the outbreak contained so it wouldn't come to Monrovia, where we had thousands of guests, presidents and ministers were there at a meeting. So outbreak anywhere is everywhere. What are some of the threats? So I gave you the fact that we still have a threat. The biology of the disease is changing, the epidemiology is changing, global travel facilitates the disease, but there are threats. I tend to show this slide. Ebola has helped us a lot. We've built a resilient system. We have a huge support where we have surveillance system in the country, but the two dip I show you was a point in time where some of the support we get from international donors stopped coming and the workers went on strike. So there is still a fragile system. The system that is so heavily donor dependent. That system gets so fragile that whatever happens tomorrow in the midst of donor support, it drops. How do we transition to develop sustainable financing for healthcare is a critical issue. The second threat is that we've done an assessment of our emergency stock, PPEs and gloves. If we were to have an outbreak tomorrow, you'll be surprised to note PPEs and gloves are now zero in country. These are all fragile systems that tell us in the midst of increasing outbreaks, you begin to see that major logistics are absent or are out of stock. What that simply means tomorrow, if we had an outbreak of Ebola, say in northwestern Liberia, that is impossible because of by road, we don't even have PPE. It's a way to reshape the model, and so much has been invested in this country. Liberia alone from Ebola got $1.5 billion investment. How we think of sustaining an investment in the country? So I will shift gear. One of the ways we've done investment now is to create these national public health institutes. I was one of those who helped to form the Public Health Institute of Liberia. I went to Thailand, I went to Norway to study that system, and we built a public health institute from the lesson we learned from Ebola, that the Ministry of Health cannot be focused on healthcare delivery and preventing threats. So we developed this institute to narrowly focus on threats, on surveillance and diagnostics, and building capacity. This concept has now spread across Africa. There is an African CDC and there are regional CDCs with the goal of building core public health capacity for surveillance and response. With funding from the World Bank and other institutions, we begin to make substantial progress. That's the only way we can save infectious disease in these neglected spots from coming to the developed spots. In order to mitigate the risks, it's an investment in laboratory system, diagnostic system. I was involved in Ebola. I was in Liberia at the time, having completed school in the US when Ebola struck Liberia. We literally had to take the samples to the border with Guinea, cross them in a canoe, drive them to Conakry, and bring the result back to Liberia for 5 to 7 days. There was absolutely no capacity to diagnose. So those are the factors that spiral. With support from partners, the CDC, you see now we are able to diagnose priority diseases like Lassa, priority diseases like Lassa, and so that gave us a complete speed in the management of any epidemic threat. I tell people every day, speed, and communication are the two critical factors. With the ability for diagnostic capacity in country, we can now diagnose and respond to outbreak immediately. The second most important investment is an investment in the surveillance system, the public health capacity. If you look at the time, most of our outbreak now, we are responding with less than 2 days, which is the standard set by WHO. You see, all in where we have zero now because we have built the human capacity, there have been investment. That's the way we mitigate the risks. Finding the core human capacity, training them, and supporting them to be in country before the expert can fly in. And we clearly have shown that our turnaround time are quicker, so we're able to contain outbreaks from spilling over. Finally, I just have this point. The international community have learned their lesson from Ebola, I have to admit, and some efforts have been made. One has been the joint external evaluation, where there is panel-to-panel evaluation where we stand. As a result of the JEE, we now have the National Action Plan for Health. For Liberia alone, the Action Plan of Health has been costed. It will take $150 million investment to prepare Liberia for sustainable financing for outbreaks. for preventing, for vaccine over 5 years. Of course, we've been part of the global health security agenda, thanks greatly to USAID in Liberia. We've invested in the One Health approach. My colleague Epstein will tell us in the One Health approach, we have a coordinating mechanism with the highest political support, with the vice president of my country serving as the head of the One Health. We have gotten involved into integrated disease surveillance and response. Lack of time, I can't go into that, but it's this framework developed for the Afro region to support HGHI. And the last point I want to speak to is the fact that we now have documented that clinical research can be used as a response. Cleveland and I have now written an article that we tend to submit to Lancet and show from the Liberia's example that clinical research can be a component part of a response. And we see this very same thing is going to be happening in the DRC where they're trying to do this 3-arm therapeutics. The work of PREVAIL NIH in Liberia is a clarion example that there can be connection between developing and developed countries to build sustainable capacity. We are running over 9 clinical trials in Liberia, and the PR on 3 of those trials we are published in high impact journal. It can be done. And to close, I will say that infectious disease anywhere is infectious disease everywhere, and the neglected spot of today are the hot spot of tomorrow. Thank you very much.